Hey, it's me, Jen again, and when it comes to thyroid RFA, Dr. Shatul Parikh is serving the South and beyond at his ENT practice in Atlanta, Georgia. We'll hear more from him after this. Thank you so much for your support of this channel. If you value this content, please like this video and subscribe. Did you know that the standard of care for thyroid nodules is to remove half or all of the thyroid glands surgically? When this happens, a patient's quality of life can deteriorate significantly. But thyroid RFA is a non-surgical way to shrink and directly target thyroid nodules while preserving the thyroid itself. You can help others hear this message by sharing this content with them. Save your thyroid. Today, I'm speaking with Dr. Shatul Parikh from Atlanta, Georgia, who's currently the only thyroid RFA provider in his state and is surrounded by other states with no RFA providers at all, including Alabama, Mississippi, and both of the Carolinas. Let's hear from Dr. Parikh about his experience with treating both local and out-of-town patients with this innovative procedure to directly target thyroid nodules and shrink them while preserving the thyroid itself.
Well, I am happy to meet you. You are actually the provider that is located closest to where I live, which is in North Alabama. And so it's exciting for me that you're in Atlanta, because now when I meet people in my hometown who say, oh, I have a thyroid nodule, I can say, well, I know where to send you.
Yeah, it's exciting. This technology, as you know, is new in the sense of what's been in the United States. I first learned about this almost 2 years ago. I had read about the technology, but as far as the FDA approval in the United States occurred about 2 years ago. And so when we hear about new technologies, especially technologies that are transformative, my instinct, and most instinct of somebody who's spent a lot of time doing this and devoted their career to this, is reluctance. And so I was fairly skeptical when I first read about it. But the more research I did, the more folks I talked to, the more patients that I spoke to who had this done, I realized that this was a very real technology. And as I tell patients, I do this now 4 to 5 times a week. And as I tell patients that this is going to be an absolute game changer in the management of benign thyroid nodules.
That's incredible. I didn't realize you were doing that many cases.
Yeah, so we're doing a lot. So this past week I did 3. Next week I have 5. Yes, we have sort of the ability to see patients from out of state. I've seen some as far as California. I've got a woman flying in from Alaska in 2 weeks. So yes, we have the ability to do that. I live in Atlanta, and we have the benefit of Hartsfield-Jackson International Airport, the busiest airport in the world. So, as they say, you can't go to heaven and hell without going through Atlanta. So,
yep.
We have that benefit. And my office is 20 minutes from the airport, so people can fly in and fly out. So it does make it easier. But for me, the reason I got busy so quick is I've spent my entire career doing thyroid surgery and managing the surgical management of thyroid patients. So organically in my practice, I've been able to recruit so many patients. So the vast, it's probably an 80-20 split of patients who I would have otherwise operated on, and now we're having RFA.
You said you were reluctant in the beginning.
Mm-hmm.
So what was your turning point for, I think this is actually something I really believe in?
When you think about the surgical management of benign thyroid nodules, has been for nodules that are cosmetically or functionally problematic, meaning you have problems, you can see it, or you have problems swallowing, you have problems breathing, or the nodule is growing in size, but it's benign. The gold standard has been surgery, and that's been the way it's been for the last, since Osler did his first thyroidectomy. And so it's the way we manage this. And so anything that is that disruptive, it's like the first electric car. Nobody believed it until Elon Musk did it. It got a Tesla to go 180 miles an hour. When all that glitters isn't gold. And so I was really reluctant, because this is something that could be transformative. And I read a lot of the data that came out of Korea, and which was very positive. They were a little bit more aggressive in the size management. So they were ablating nodules that were a centimeter and a half. And I said, well, listen, these are nodules that are otherwise asymptomatic and may not grow. And it wasn't until I had the opportunity to speak with some surgeons in Brazil and South America and talk to them about their experience and said, hey, listen, we're doing this on 3.5 and 4 and even 5, and they do it on larger nodules than that. My experience has been the sweet spot is 3 to 6 centimeters is really the sweet spot for this procedure on the really large nodules, the 8 and 9 and 10 centimeters. Yes, we can provide some benefit, but it's not curative, and symptoms could still persist. But again, we're in the early days now, and I'm really honing down on technique and how I'm doing things and kind of patient selection, which I think is really important. So yeah, I mean, but the reluctance really stemmed from sort of ingrained patterns, and doctors, we tend to be dogmatic, which is how we get to being successful. But part of with that dogma comes unwillingness or reluctance to change, and so it was eye-opening. I mean, after my first case, I was flabbergasted 3 weeks later when the nodule was, maybe about 6 weeks later when the nodule was, half the size.
Well, I'm so glad that you're on board with this now. When I was thinking about talking to you and how, like, you're in Atlanta, you're the only provider that I know of in Georgia offering this. There's no provider in Alabama. There's no provider in Mississippi. There's no providers in North or South Carolina.
Correct.
It's like the whole South. It's like they all could come over to Atlanta and take care of their nodules. So it's just, I'm just so glad.
I think the hard part with it is it's a great technology. It's not easy. And that was the hardest part for me. So there's a lot of people like, oh, well, if you can do an ultrasound biopsy of a thyroid nodule, you can do an RFA. I disagree. This is technically challenging. There are risks associated with this. And as a surgeon who's operating on thyroids every single day, I mean, still my practice, I do 10 to 12 endocrine surgeries a week. So I am very comfortable with the anatomy, and I've done over 5,000 thyroidectomies. So I'm very comfortable with the anatomy. But it is, for the non-surgeons who like to do this, it's a little bit harrowing because you're putting a radiofrequency electrode near the carotid artery, the jugular vein, the recurrent laryngeal nerve, which if you're not a surgeon, you've never seen or held or touched those structures. It's very disconcerting to have a high power emitting source very close to those structures. Now, that being said, it's an incredibly safe procedure if you know what you're doing, you have good experience. But I do think that there is a barrier to the procedure because it's difficult. And as my father used to say, if it was easy, everyone would do it. And that's really the truth of this technology. It's hard. And before I go to sleep, I've got 2 this Wednesday morning, and Tuesday night I'll make sure I get a good night's sleep, and I think about each case and I study them because it's hard. Thyroidectomy is taking thyroid nodules out has become kind of second nature to me, but these procedures still require a little bit of thought and preparation, and they cause some angst.
You are feeling like this is something you're pretty confident in now. Are you offering any kind of physician observation for any physicians to come and watch what you're doing and maybe gain some skills and spread the word?
Certainly. Yeah, so I'm certainly not proprietary. I believe that greatest good for greatest number when it comes to healthcare, and so listen, if more people are willing to do this, we have talked for other surgeons to come and watch us do this. And our setup is really, really unique, which is another part of our success. We have the ability of owning our own operating room. So we're able to do these procedures in our own surgery center, which no one's put to sleep, but having the benefit of a really large operating theater. I use a surgical scrub nurse. I connect, I have the benefit of having all the surgical supplies. We do it in a very sterile environment. So again, barriers to this are not all physicians have access to their own surgery centers. And so again, it's part of, well, yes, here's how we do it. And I'd love to teach you how to do it, but I need to know that I'm teaching someone that can replicate our path to success. So we're slow going in the bringing folks in and kind of talking to them about and teaching them how to do it. Our techniques are sort of honed in. Our success rates are really good, but I just want to make sure that those that come to watch us have similar sort of setups.
That absolutely makes sense. And I think that definitely, in Alabama, since that's my state and I know a little bit more about what's available here, UAB, University of Alabama, Birmingham, that's pretty much the main hospital to go to in Alabama if you've got any kind of complaint. I went down there actually, it's been over a year ago now. I had a baseball-sized kidney cyst. And so I was pursuing sclerotherapy. So I went down there to see this interventional radiologist about this. And I mentioned to him, I've had this procedure done on my thyroid RFA. And I know that, as an interventional radiologist, you do these kind of procedures on other parts of the body. Do you potentially think this might be something you would offer here? And he was kind of just like, well, I mean, we can just do the same technique that we use on other parts of the body in the thyroid. And I thought, I don't know if that's necessarily how it works. And at the time I wasn't aware of the nuances of thyroid RFA and how it requires a different, awareness of the structures in the neck. And so I would love it if there were physicians at UAB that would be interested in taking this on. If I can get an audience with some of these physicians, I would really love to send some of them either your way or, to someone in the South who can
Sure, yeah. Like I said,
advise them on that.
There's three barriers that I see. Number one is training, and I have no doubt that the folks at UAB are very comfortable doing this. But number two is having the physical plan to do this, operating theater, so an interventional radiologist, that'd be good for them. But the third biggest barrier is the insurance issue with this technology. And what we're finding is that a lot of academic institutions don't have the ability to say, okay, we get it, you have insurance, but here's a self-pay price. And there's, some of the big hospital systems, they're so big and they have so much red tape that they don't even know how to negotiate something called a self-pay, or what we call an all-inclusive. You do it all, one cost, one fixed price, because we have the ability to have the operating theater and all the equipment, and so it's just one fixed price. So yeah, but absolutely willing to help how I can. Like I said, I believe in the technology, and I'd like to spread the word. But I do think that you're gonna see, which is what you're seeing, is a lot of people who say they want to do it, they try it, they do one or two cases, and I will tell you, the first few cases I did, very frustrating, very difficult, hard. There's a lot of nuance to the technique. You have to do a lot before you really feel good about it.
So what's the process when a new patient finds you on Google and they're interested in pursuing treatment with you? What is the process for that patient to get from Google to your office?
Sure. So we have a patient coordinator who manages all things thyroid. So it's good in our practice. I manage a lot of out-of-town patients already with my thyroid and parathyroid business. So the system's already set up. So they would call our office and speak to my coordinator. Her name is Myra, and Myra will talk to her. She's very well versed in this technique and procedure. But one thing we do is we request the records to be reviewed. So she would request that the records be sent down. I take a look at them and say, yes, this is a good candidate. It's not a good candidate. Here's the last step. So my rule, there's certain requirements, right? Certain size of the nodule, certain disease states. So I have not, there's some countries where they're treating small thyroid cancers with RFA. I'm not doing that just yet. So I've got to make sure that the disease state is appropriate. They don't have significant hyperthyroidism. They don't have any significant medical issues that would preclude them from laying on their back for 30 minutes to have the procedure. And then that they've also had 2 benign biopsies. That's very important that they've had 2 benign biopsies or 1 genetic negative biopsy. So you can have a biopsy, and if it's indeterminate, and then you have a genetic test that's negative, that's 96% sensitive. So we're taking 1 benign genetic biopsy is appropriate. So I'll review the records, and then Myra will call the patient back and say, yes, you're a good candidate for this. And then she'd set up the visit. So ideally what happens is the patient comes in the day before the procedure. I evaluate them. I repeat the ultrasound, make sure the nodule hasn't grown. And I've learned that from a mistake that somebody sent an ultrasound that was 8 months old, and they came in and I did the ultrasound and the nodule had doubled in 8 months. And so that was hey, we can't do this. We need to talk about something else. And so we do an ultrasound in our office the day before, make sure the nodule, again, and it allows me to look at the vascularity or the blood flow to the nodules, and I can help talk to the patient about predictive value of success, because the vascularity is really important for the nodule for how much it shrinks. So we see them the day before, then they stay overnight, and we have hotels that we're contracted with that provide a very reasonable rate for patients to stay in town. And then they have the procedure the next day, and then they're welcome to leave that day. I like them to not get on a plane or leave the city for about 2 hours, just to make sure that there's not an acute complication. I've never had one, but I just like them to hang out, just to make sure that something doesn't go awry. And if something does, we have a hospital that's right across the street from our surgery center. We can help manage them there. We have our own office, which we can help manage things. So that's kind of the process. They leave, and then after that, they can be routinely followed up by their physician at home, whether it be an endocrinologist or primary care physician who's ever ordering the ultrasounds. We stay in touch with them, and we request that they send us their follow-up ultrasounds. I'll communicate with them and say, hey, listen, this is the reduction we've had. So it's not like we do the procedure and the relationship's over, but we certainly we don't tell patients they need to come back. Now, my local patients, I bring them back because I like to high-five them when I'm like, hey, listen, your nodule just shrunk 70%, and I like to see them and kind of have my hands on them to know that. So those are our local patients, but our out-of-town patients, happy to follow up with their electronically after that.
I'm curious about this because this is a problem we're seeing a lot in our Facebook group. Patients who travel for this and they follow up remotely via, ultrasounds with their local doctors, is that sometimes the local doctors just have no idea what to make of what they're seeing on ultrasound. Do
Right.
you have any contact with these patients' local doctors to kind of help guide them through this process?
Yeah, that's a great question. It's hard because knowledge of this. Now, I will tell you, endocrinologists have really come on board with this. I've done a lot of education in town in the metro Atlanta area for sure with endocrinologists that here's the technology. We're actually doing a big talk in Atlanta next month and having all the endocrinologists come in and kind of saying, here's the technology, here's how we're doing it, so that they're aware and they can offer this to their patients, because a lot of these patients just get sent off for surgery. But we do have, what I tell the patients to do is happy to communicate with their primary care for endocrinologists. If they have any questions for me, I direct them to some of there is obviously, as you know, tons of commercial information about RFA. I can provide their primary care physician with the pinnacle journal article that came from Korea that talks about the technology. So there's a lot of ways to communicate. Listen, like me, there's a lot of people who are skeptical about this and early on, and so we have to work through that skepticism, and we do that by the results that we see on ultrasound.
Absolutely, yeah. I've had a lot of patients who have posted in the group that their local physician was kind of almost mad at them for having RFA. And I'm hopeful that that's going to change the more these doctors are seeing patients decide, I'm going to go out of town if I have to get this done in order to save my thyroid. Because that's the thing that most patients say, that's their main goal when they pursue this, is they want to save their thyroid and their thyroid function. It's a goal I think that so many of us want to see this change, this attitude of angst towards RFA.
No, for sure. And listen, organ preservation is super important. I think in the endocrine surgery community, we take out too many thyroids. We do too much thyroid surgery. We operate on too much with the advent of genetic testing and the overutilization of imaging, whether it be in the emergency room. We pick up so many incidental thyroid nodules. They have a needle biopsy. Those needle biopsies are indeterminate or they're benign but large, and people are recommending, so we're just doing too much thyroid surgery. So as a thyroid surgeon, for me to say that is pretty, because I love doing thyroid surgery, enjoyable surgery. So patients are happy with the end results, but we're just doing too much of it. If we can find a technology like this that's low risk, high probability of success, there is a risk of no improvement or minimal decrease in size. But what I tell patients is, if we can just stop this thing from growing, that's success enough. Not to mention the reduction in size. So there's a lot of potential benefits, and I'm super excited about it. I think I see a big shift in my practice towards this, and glad to be on the forefront of this. And we're talking about this in a lot of our sort of academic settings. And but again, in the country, I think my guess is there's maybe 5 of us that are doing a lot of this. I don't think there's a lot of docs who are doing more than 1 or 2 a month. I mean, there's only a few of us that have a high volume.
I spoke with Dr. Ralph Tofano last week, and he said that he was doing like 10 a month, and that, that was a high volume. And I'm like, wow, I have some people who've left questions from the Facebook group. So you mentioned earlier about the cash price that you guys have, basically an all-in-one price. Do you allow patients to file on insurance through your practice, or is it just the straight cash price option at this point?
Yeah, the problem with is the insurance companies that we've checked them all, we've looked at them all. It is our understanding that there is no insurance company that is, the code that we use for this is an unlisted code. And so there's no reimbursement, there's no fee schedule for that. And as you know, this technology is quite expensive. The radio frequency probes are expensive. The equipment is quite expensive. So we have not found, and we do offer the patients to say, listen, here's the bill. I mean, they pay us and they can submit the bill to their insurance company and try and what's called subrogate with their insurance company to try and see if they get any payment. But, we've called all the payers and we've asked them the question, hey, what is this code? They said, we don't have a reimbursement for that fee. And I think that's the way most are handling it. I believe the guys at Hopkins and all that are doing it the same way.
Yeah, I've heard that some of them file and some of them allow you to, like you said, to do reimbursement. It varies quite a bit. And, patients in the group are asking a lot about what the costs are. It's such a difficult question to answer because the costs are so different everywhere and there's so many variables. Because I don't know each and every provider what their setup is, I always tell people you just need to call and ask. And I'm sure that the practice is well versed in answering that question. So I always
Sure.
try to defer that question to the individual provider.
Cost for this procedure is the time, and then the expense of the equipment, and kind of all that bundled together.
This person is asking, is RFA safe for larger nodules? What's the ceiling on size that you would be willing to treat?
So I've gone back and forth on that, and right now I think I've sort of settled out. And every patient is different. Every patient is shaped different. Everyone's thyroid goes to different kind of. Some grow downwards into their chest. Some grow out laterally into the neck. Some go medially into the larynx. So they're all kind of different, and it all depends on the size and the shape of the nodule, also the size and the shape of the person. So everyone is different, and access is really important for us to be able to get the right angle. About the upper limit that I'm really willing or want to do, I think because again, people are spending time, money, effort, and going through some discomfort to have this procedure. I want it to be successful. And so 6 centimeters, maybe 7 centimeters is probably about the max that I really want to consider. Now, again, each individual patient is different. So evaluate everyone. But I had a guy come in the other day at a 10 centimeter. There's no way. I was unfortunately drove in from North Carolina. He was the guy that not really changed in size, and that's just not one that I would consider. Listen, just because you can doesn't mean you should. And we can ablate these, but should we? Probably not.
Have you ever known of a case to have surgery being done after thyroid RFA? This is a question that came up in my last interview, where a lot of physicians who are not familiar with RFA will claim that RFA is going to cause scar tissue to develop in the neck that's going to make a future surgery dangerous. Have you ever encountered a case where you've done surgery on someone who's had RFA previously?
So no, I have not.
Okay.
I mean, the technology is way too new. Do I think it's going to happen? Likely. Like I said, I think there are some patients that RFA, rare, a small minority, that RFA is either didn't work or the nodule was too big and they're still continuing to have compressive or symptoms from it, and we end up removing it. If the procedure is done correctly, all the scarring should be within the capsule of the thyroid gland. So if it's all within the thyroid, it should not disrupt. There shouldn't be any scarring in the strap muscles, which overlie the thyroid gland. There shouldn't be any scarring in the parapharyngeal musculature or tissues, which are medial or to the middle of the thyroid gland. If the technique is done properly, all the scarring should be within the nodule, which shouldn't affect anything.
And that's kind of what I was thinking, as I was reasoning through it as a person who doesn't have medical training. It made sense to me that it would not cause that kind of adherence to the surrounding structures. But, so many patients lack the confidence to say things like that to their physician because they don't have the training. So it's always good to hear kind of an explanation like that. People ask this question quite a bit in my group. People, when they hear the word radio frequency, they think radioactive. And they don't understand that there's a huge difference between the two. Do you have that happen a lot in your practice where patients come in and they think that it's the same thing as radioactive iodine to have RFA?
Yeah. I mean, it's again, somebody who's non-medical, and radioiodine can be used to treat certain thyroid conditions, so they think that it's similar. So obviously it's just education, and that I think people will understand. Listen, very, very different. This is an energy source that is delivering energy to the thyroid to help it sclerose and scar and shrink and cut off blood supply, versus radioactive iodine is meant to kill thyroid cells, all of them indiscriminately. And so it's just education.
I have a lot of patients ask me about goiters and, if this could be done on a goiter with no nodules. And I try to explain to them that I don't believe that it would serve the purpose that it's intended to serve on a goiter without a nodule in it. Could you maybe give a little bit of an explanation on that maybe would be better than what I can tell them as a layperson?
I don't use the word goiter in my practice.
Okay.
I think it's sort of an antiquated word. We talk about nodules. We talk about thyromegaly. So there's nodules, which are growths in the thyroid gland that can be benign or malignant. The vast majority are benign. When nodules grow, they can make the thyroid, by definition, grow because the nodules are within the thyroid gland. You can have multiple nodules in the thyroid gland, a single nodule within the thyroid gland. And then you can also have something called thyromegaly. That's an enlarged thyroid gland without any nodules. That is a very, very, very rare condition. Actually, rarely ever happens. There are conditions like hyperthyroidism or thyroiditis, which are inflammatory conditions that can make your thyroid gland grow without having nodules, but that's the very, very small percentage of enlarged thyroids. The vast majority, greater than probably 95% of enlarged thyroids, are from multiple thyroid nodules. So a lot of people throw around the word goiter to mean a bunch of things, and that's why it's important to understand what goiter means. Does it mean that your thyroid is enlarged without nodules? Well, then yes, that is not a condition that radiofrequency can treat. But if your thyroid is enlarged because of nodules, then yes, certainly RF in the appropriate setting is the right way to do it.
I thank you for explaining it that way. If you just have an enlargement of your thyroid that is being called a goiter, sticking a radiofrequency probe into it is not going to help any at all. Well, this is my personal story. When I was diagnosed with thyroid nodules, I didn't really have any symptoms. I didn't know they were there. A few years later, I had just been living with them because it was 2014. RFA was not available, and I didn't want to have surgery. And in 2019, I took a round of antibiotics and had an allergic reaction to those antibiotics. In the process of that allergic reaction, I actually had a case of thyromegaly develop, and the nodule in my neck doubled in size rapidly. We have 2,000 plus people in our Facebook group now. I've not encountered anyone else who has had that happen to them. And I'm just curious, with the volume of patients that you're seeing, have you encountered a similar situation where someone has had something like that, not where a nodule has grown over time on its own, but where an external factor caused a nodule to increase rapidly in size?
So the only external factor where we see acute growth in nodules is something called a hemorrhage of the thyroid gland. So if somebody excessive coughing, they bend over to lift something up, they bear down and they can bleed into their nodule, or it just happens what we call idiopathically. Sometimes people just bleed into a nodule for whatever reason and it can expand. That's really the only external factor as far as drugs or disease states. Obviously autoimmune conditions can make your gland. If you have an acute Hashimoto's episode, or pregnancy is another reason where we see nodules grow for some reason. So yes, there are those external, we'll call them factors, but they're internal, pregnancy, autoimmune conditions. But really the only thing that can cause it, you're otherwise well and it acutely grows, what I've seen is what's called a thyroid hemorrhage.
Yeah, it's so funny because it happened to me, and I keep thinking, okay, at some point in this advocacy journey, I'm going to encounter someone else who's had a similar story, but I haven't encountered that yet. But I have encountered a lot of people who've just have felt like they were or were definitely not a good candidate for surgery. And so I'm curious if a greater number of patients coming to you for this procedure for that purpose, or if it's for just a desire to not have surgery.
Yeah, I would say the vast majority of patients who are seeing me for this are people who don't want to have their thyroid removed. Rarely am I seeing patients who are a poor surgical candidate for, because what we find is that in my hands, thyroidectomy, a lobectomy takes, taking one side, it takes 30 minutes, taking the whole gland out takes 45 minutes. It's a short course of general anesthesia. People wake up. So you have to be pretty sick to not meet criteria for surgery. So that's not, in my practice, that's not really a rate limiting step for us. Now, I'm sure across the country, there are thousands of people that don't have the right health to have thyroid surgery. But in my practice, it's a pretty low factor of people. The vast majority are people who are otherwise usually young, sometimes old. I've done somebody as old as 78 years old who just was like, I don't want my thyroid. I was plenty, he had great health. He was a farmer, super burly, and could probably have surgery and have done just fine. But he's like, I don't want my thyroid out, which I totally understand. But we've done somebody as young as 22. So people who just don't want to have, they're young and they don't want to subject themselves to the risk of being on lifetime thyroid medication, or potentially the low risk of surgery, which are quite low, but they don't want to scar. And there's been a myriad of reasons why, but the vast majority of people they just don't want to have surgery.
I really appreciate everything you've had to say, Dr. Parikh, and I would love to point more patients your direction, especially from my state of Alabama. How is the best way for a patient to find you, to connect with you about becoming a patient and pursuing this?
Sure. So we've got a website. So it's ours is radiofrequencythyroid.com. And it gives them a lot of information, a little video with us, and it tells them exactly how to contact Myra, who's my coordinator.
Do you have any last little tips either for doctors or for patients who are just now learning about this? What would you have to say to them?
Yeah, I would tell people that, especially surgeons, think you consider this in your armamentarium before we reflexly offer surgery. I would tell patients to always do your research and make sure that before you pursue a new technology, you make sure you go to somebody who has a good experience doing this, that cares a lot about this, that this is not something that they just dabble in. They don't do this and that and this. This is really something that they focus on. They focus their career on. We're lucky in the United States that we have people who are able to kind of super specialize, and I think that's very important for this specific procedure. You need somebody who spent the greater part of their career studying this disease, understanding, because it's really important for patient selection. And then for referring doctors, the best way is, if you're unsure, ask. Have the patient have a consultation with us. It's a simple yes or no. Yes, you're a good candidate. No, you're not a good candidate. Or in between, if you're in between, hey, let me take a look at you myself. But most people we can figure out pretty easily yay or nay if you're a good candidate for this, just by looking at an ultrasound report.
Thank you so much for watching. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next interview right here.